Hi, good afternoon everyone, and welcome to our final HiPPO Group Methods at Manchester session. So my name's Elvey, and I'm based in the Centre for Primary Care, and I think I'm a bit of an affiliate HiPPO. So we've got two of us presenting today, so I'm going to start, and then got my colleague Sharon Spooner. So we've both got presentations, obviously, about professional identity. Coming from quite different viewpoints. So I've got a social science background and I've worked in applied health research for quite a few years. Sharon is a GP so I don't have a clinical background, but Sharon's a GP who combines clinical and academic work. So hopefully it should be interesting to have two slightly different takes on professional identity. Okay, so I'm going to go first. So my presentation is an application of the persona technique to researching professional identity in pharmacy, and it's based on research I did for my PhD, which I finished a couple of years ago now. So this is a methods-based talk, but before I get into the technique, I'll just give you a really quick bit of background on professional identity and on pharmacy. I know you're probably from quite a range of backgrounds and probably know pharmacy people here. So first of all, in terms of professional identity, so when I talk about professional identity, what I mean is who a person is in relation to their work. And there are obviously various ways of approaching this, and the theories and approaches used for studying and researching it tend to be drawn from sociology and psychology, mostly social psychology. So this whole series of talks has been about researching healthcare organisations, and HiPPO, of course, is a policy-focused research group. So thinking of why professional identity is relevant to healthcare organisations, so if we take an organisation as any group of people, and that could be a profession. So a profession it's important for a profession to have clear agreement on its direction and purpose, and to understand the identity of its members. Or think of the NHS as an organisation, either the whole NHS or probably more realistically different units of it, so a hospital or a primary or community team. We have GPs and pharmacists and nurses. Increasingly people work in multidisciplinary teams, but to put those teams together, it's actually important to understand the individuals there, their identity, how they can work together, how they see each other, how patients see them, what patients want from them. So just a couple of ideas about why professional identity is important to understand. So I was working in the School of Pharmacy here in Manchester at the time, and with pharmacy, I think it's probably a non-pharmacy audience here. So when I say pharmacists, I mean pharmacists who work in hospitals and also in community pharmacies. And by community pharmacy, I mean the local chemist shop, so whether that be Boots, Lloyd's, the big chains that you'll have seen, pharmacists in supermarket pharmacies, or your traditional corner shop, village chemist shop. And in all of those pharmacies, there will be one pharmacist, and then they do have other support staff working with them who aren't necessarily pharmacists, but not to labour the point, but that's what I'm talking about, pharmacists. And in terms of the workforce in Britain, the community pharmacy is where most pharmacists are, so about 70% of the profession are based there, about 20% in hospital, and then there are other various roles, but that's the main one, so community and hospital pharmacists. Okay, so pharmacy as a profession, obviously all professions constantly evolve and change, but pharmacy has undergone some quite particular changes and very big changes. So up until the 1960s, pharmacists physically, it's called compounding, they mixed up medicine powders and liquids and made medicines in the back of their dispensaries. Of course that doesn't happen anymore, so from about the 1960s that was moved to factories, so pills are made in factories and come to pharmacists ready packaged up. But so for pharmacists, that's a big change to what the profession is actually based in, and so their training and the kind of services they're expected to do now are around being a more clinical professional, advising on medicines, having more contact with patients, and even carrying out public health service focused services. So could be providing contraception, providing stop smoking services. So those kind of things, and those are obviously driven by health policy. So I've already said that professional identity, I think, is relevant in times of change. So these are kind of examples of how pharmacists' roles and the expectations on them have changed. So it's important to understand how people see themselves fits in with those plans and aspirations that come from policy at the top level and filter down into everyday practice. So or in reality, of course, the supervisors knew about all these changes in pharmacy, and we knew there was a big gap in the research in that there was no up-to-date understanding of professional identity in pharmacy in Great Britain. So that's where the study fitted in. And we decided that I was going to do a qualitative piece of work, take things back to scratch really, and look for a fresh understanding of the issues. And reading around, I came across the persona technique. So the technique itself, the persona technique's been pretty much developed and tends to be used a lot in product design and fields related to product design, so particularly around software design. And it's used to design for designers to help understand the users of their products and what their needs are. So a persona is a representation of a person, so it's abstract. And when you create a persona, you are really conjuring up an imaginary person. And as I say, in design, this persona will then help the designer to build products that people want to use. So a persona is just one way of representing people, and there are other forms of representation. So things such as profiles, archetypes, scenarios. You might not have used those particular terms, but just hopefully this is a really simple example of what I mean. So I've just pulled these off the internet. So these are examples of how you could profile a person, and if you don't like these, it doesn't matter, but you might have seen something along the lines of this before. So you could have Tina, the learning focused teacher, or this one's Dave, the information jockey, and they're supposed to give a snapshot of a type of person, could be their demographic details and their kind of interests and values, to get across the idea of a type of person. So I think the idea is hopefully quite simple, however, not to suggest the method is simple. So Cooper, who is the main writer that the methods that I read tended to draw on, who's written about developing and using personas, emphasises that the personas must be developed with rigour and precision, and that the value of a good persona will come from the detail and specificity. So although they're fictional, they do need to be credible. So it's not something you throw together in 5 minutes, and it's also not a wild sort of figment of the imagination. It will actually be based in reality. Okay, so in terms of my study, so my research questions really were things such as who are pharmacists, what are they like, is there such a thing as a typical pharmacist, are pharmacists all the same, or is it possible to discern different types? And I had my method, so I was going to use the persona technique. So I needed a sample and some participants. So as I say, I was based in the pharmacy school, and I just approached pharmacists working in a department. There were quite a large number of pharmacists working there as teaching staff. So this was really, it was a pilot study, and as I say, because it was part of my PhD, it was a learning exercise for me as much as of anything, and a chance to play or experiment very rigorously with the technique. So the sample was a convenient sample to an extent. So in terms of what I actually did, so invited the pharmacists to take part in interviews, and I did these in focus groups or just group interviews. Really, they were quite small groups, and so I outlined the persona technique, and then I pulled together some example personas that were just very broad outlines. So it had some sort of headings, so some demographics, so just the person's age, gender, ethnicity, something about their role, their knowledge and skills, and their values and preferences for type of work. And I just put some very brief details in so that people could hopefully see the kind of thing that I was hoping to generate through the groups. So they were designed to represent types of pharmacists that might exist. And then I asked participants my research question, and they all said that there wasn't going to be one type of pharmacist, so they thought we could probably come up with quite a few personas. And then so we got to work in the groups drawing those up. And it was I kept the groups sector specific, so it was community pharmacists together and hospital pharmacists together, and asked people to focus on their sector of work because that's what they would understand. And again, in terms of the personas needing to be based in reality, as I say, I sort of come up with some really brief examples to give people, but I chose the people I did because I thought that they would generate valid data because they worked as pharmacists, so that's the rationale behind getting them to take part. So to be honest, initially I was a bit anxious about the whole thing falling flat because I hadn't used the technique before. I thought it might not be familiar to participants, or people might think it's a bit silly, a bit of an odd thing to do. But happily this didn't happen. We actually had really good sessions with lively discussions, and people, we filled in the personas, and people used, so they drew on their experiences, talked obviously anonymously about people that they had worked with, and I thought people to be a little bit creative. So I mean, at the start of the sessions I said people could draw, people could use pictures if they didn't want to just use words, but nobody wanted to be quite that creative. But although it was mostly focused on professional identity, to kind of warm up the discussions, I asked people to maybe suggest where these characters would live and shop, or to try and bring them to life a bit more. So it generated a lot of discussion, and people. It wasn't a narrative approach that I was using, but people would tell stories, based on their own experiences and their own work. And so to physically capture the data, I just had big sheets of flip chart paper, and I was the scribe because people were busy talking, so I wrote up headings and then just noted down the keywords and phrases that people were saying, but I'd also got consent to take the discussions, which I was glad that I did. So I think I ran 8 groups altogether, and they generated 32 personas and had over 9 hours of tape. So in terms of the analysis, so the sort of textbook version of how to create personas, the methods that I've read tend to be aimed at people in business, the way they're written, so they are really different from traditional academic methods text that you'd read, but they do describe processes of gathering together data. They do talk about typically using market research data, maybe interviews with some product users or experts, and then following a range of activities where you draw a persona, maybe present them to colleagues for feedback, refine them more and look for consensus, and then produce these personas that are these understandings of the product users. So I'd say at that point my analysis probably departed a bit from that, and what I did with the data that I had, so the typed up personas, I transcribed all the discussions and then followed a process that I think will be familiar to anyone who's performed systematic analysis on quantitative data. So I started to compare and contrast all the documents that I had, and it was was quite easy to spot similarities between some of the personas. So although I had 32, I felt there was certainly an element of data saturation in some of the groups that started to describe quite similar types of pharmacists, or some of the traits were similar. So that was easy to quite quickly start assimilating some of those and distilling them down. And then some of it was more complex and took longer, but just really a continual process of looking at the data. And I guess I had a priori themes and ideas to some extent, so I knew I wanted to identify types of people, the sort of constructs like knowledge and values. I knew that I was going to look for those in the data, but I had asked open questions and very much wanted to see what was in the data, looking for things that maybe weren't expected, and the more unusual things. So similar to looking for deviant cases, and hopefully make the most of the data. So from 32, I reduced the number of personas down. I think I had 9 or 10, and I had outlines that I typed out, but then there was a lot of detail around that I could write around or talk around. And I wasn't entirely sure how it was going to be presented ultimately, but at that point I took it to a conference. And that was positive because these personas seemed to generally make sense to the audience there. And it was a pharmacy practice conference, so it was academic pharmacists and pharmacy practice researchers. But then I knew that I wanted to extend the study, keep using qualitative methods, but explore the ideas with a more grassroots sample, as in not just people based at the university. But I wanted to use what I did have from these personas and to build on that and extend it with this wider sample. So I decided to create a visual tool that could be part of a more traditional semi-structured interview. So as I say, I went to the conference, and then after that I looked again at the personas and discussed it again with my supervisors, and came up with, I've got the number down to 8, and then I spent some time searching for pictures that could hopefully represent the essence of the people I had. And I didn't want to, the pictures that I showed you before had quite a lot of text around them, but I didn't want people to have to spend time in the interviews reading that, so I wanted to try and put something forward that something visual people could just look at really quickly and respond to. So this is for pictures. Sorry they're not as sharp as pictures that could be on there. But I'll take you through those. So starting from the top left and going along. So that's the top left one, is meant to represent that very old-fashioned traditional role I talked about, which is tipping a bottle of some sort of liquid into a medicine bottle. The next one is very stereotypical, supposed to represent a local pharmacist. You can tell this was a few years ago if you know anything about how the pharmacy local market's gone, but it is a stereotype of a young male pharmacist focused on money, dipping in and out of different pharmacists, and not always the most positive stereotype, but quite a big one. The third one is the traditional owner-manager who would maybe own his own shop in a village, knows the local community, so can actually be a real pillar of the community, really focused on his patients, will give them lots of time, probably towards the end of his career, and that's him looking at the golf course in the little picture, and again, stereotypes. The next one is the new generation of that community pharmacist, so which often typically is a younger female, equally customer focused, but she'll have come from a very different training and have been explicitly trained to be doing those clinical services and talking with patients. And then on the bottom row, the first one on the left, his pictures are one standing in a hospital bed, so that's the hospital pharmacist, very clinical role, going on ward rounds, face-to-face contact with doctors and nurses, advising, on a high level, serious conditions in the hospital. The next one along is a whole role really that's very focused on dealing with information and not necessarily being face-to-face with patients, but taking queries from other professionals probably and looking pulling together, if there's a very complex case, we need to go to the reference sources and read academic papers, and then put that into a format that a clinician can use or advise on a complicated case. And then the next two are more business focused. So the first one is an area manager, which is a role a pharmacist would do. It would go, if it was a big chain of pharmacies, do a business management role, going across different pharmacies in a region and going around and training them on doing services. And then the right hand one would be a really senior manager, so probably in the NHS, somebody in a strategic role in a trust. So this is what I put forward to people, and as I say, it's just one part of what I did. So in the second stage of my PhD, I went out and interviewed pharmacists, and so also included that group, pharmacy support staff and doctors and nurses and patients, and asked them questions about who are pharmacists and what do they like. And then partway through the interview, I would just bring this out and say, here's some pictures, and these are designed to represent types of pharmacists. Could you tell me, give me any thoughts? And some people responded straight away. Some people were less sure. I think thought it was a bit of nothing for me to bring out in an interview. So people really didn't have anything to say. I'd maybe say this is supposed to represent a really traditional pharmacist, and that would trigger a response. I think, the one in the top left, that was one of the most interesting in terms of how people responded actually. So people talked about that traditional role and how things obviously changed, but I put it on and it was part in jest, and I just thought people would say, well, that's old fashioned, that's gone out with the dark ages and nothing more to say. But actually they did say it was old fashioned, and they said it's not like that anymore, but they recognised it so clearly. And sometimes in the interview before this had come up, there was a similar feeling that was expressed, but people were had quite a sentimental attachment to that kind of work. And also, because that is so clearly recognised, and it's certainly not what pharmacists are supposed to be doing anymore, they're obviously not, but with all the new roles that they have, one of the main findings from my PhD was that very clear identity has been lost, and an equally clear identity hasn't been found yet. So I'm still quite attached to my old-fashioned pharmacy picture. So I think that's pretty much what I wanted to say, and that's what I did is one example of applying the persona technique. People who use it talk about the persona life cycle, and what I really focused on was they actually call it the conception and embryonic stages of developing the persona. And in business, there'd be a different focus in how it's used to go on to sell products, and I really probably took those earlier stages, used it to produce something which generated some discussion in my PhD. So I've not seen it used very often in healthcare research. The third bullet put down, I went to a qualitative health research conference in Canada a couple of years ago and saw a really nice presentation where somebody had used the persona technique. But again, they did say that they recognised that not many people use it. The top two references on there, if you want more detail, that's the main sources that I used in terms of learning methods. And then I went on, as I say, this was a pilot study in the early stages of my PhD, and I went on to interview a wider sample, and then I eventually settled on 9 identities in pharmacy, and if you want to read about those, that's okay. So, thank you, and I'm going to hand over to Sharon now.
If any of you were here 2 weeks ago, well actually in another place, but at the session 2 weeks ago, one of the HiPPO team, Donna, presented in quite a lot of detail on situational analysis. I'm going to do something slightly different because I set about doing an exploratory project looking at the narratives of senior doctors in the NHS. Didn't really primarily think I was going to be looking at identity, But because I got involved with situational analysis, that's just the way it turned out. The plan is to give you a very brief description of what situational analysis is, how it works, what it's intended to do, organising data, spotting the links and sometimes spotting the gaps, and how I then applied it to these narratives. Essentially, without going into all the theory, your data needs to be kind of digested in some way before you do it, whether it's the use of grounded theory, as Adele Clark, who described the method, suggested, or it can be by other means, and mine was mostly a thematic analysis. And then I'll just show you some of the connections that are actually evident once you get looking at it. Situational analysis, the book is actually online available at the library if you're interested. It is a way of organising data. It uses a kind of an approach that's grounded in grounded theory and that sort of methodology. And it does an interesting thing in that it will allow you to have multiple layers of concepts and understandings. So it will take data that's really quite partial, complex, contingent, contradictory, multi-voice, all those sorts of things that get very, very difficult to handle with some forms of analysis. And you approach it with a lot of openness and flexibility, probing it, questioning it. It will deal with messiness because it just does. And it will deal with conflict that's in there as well. Not everything will agree. Very briefly, you have 3 maps. One is the situational map, which talks about the situations, the organisational structures, the structures that actually set up the place where people will work. The social world map, which is constituted by social worlds, but also we're thinking of teamwork. We're talking about interactions between people who are trying to perform a task. These are things that are not set in stone. They are influenced by the people who operate within them. And then the positional map, which is very much more looking at the individual. How do they feel about themselves? How do they feel about their work? How do they approach things? What are their values, their expectations? So these are the sorts of things that you'll find in the maps. Obviously, these are quite generic lists, really. They can be as detailed as you want. When it comes to actually looking at doctors' narratives, the question is, how might those maps look? Well, if you have inside knowledge or if you go and do a lot of background reading, you can start populating them. Just some examples that might be there for the NHS. Obviously, management structures, things like evidence-based medicine, societal expectations, political influences, lots and lots of big things that individuals can't easily change. They're there and they set the scene in which people are expected to work. Similarly with the social world map, picking out a few, relationships with clinical colleagues, nurses and therapists, collective identities, how people operate as professionally accountable, and sometimes defending colleagues. In the positional map, things like aspects of medical identity itself, target orientation, acknowledging limitations, and sometimes deviations from accepted norms. So how does this help with medical identity? I think it might be useful just to have a few words about what medical identity might be like. Becker was the person who has been unmatched in his study of the attitudes developed by medical students. Clinically acquired attitudes, approaches to patients, approaches to authority, all sorts of things like that. Fradson's work in the 1980s looked at how doctors developed characteristics in more complex clinical situations, so slightly further down the line. Digby wrote about the multiple influences operating within medical society and wider society as well as being influential, and Tallis took that a little bit further, bringing in the political, socio-cultural and economic factors. However, Moll's writing about an enacted identity I thought was particularly pertinent to the work that I was doing, because this was talking about how, from what you could find out about how a person acted, how they spoke, their attitudes that they expressed, you didn't really have to know what was going on in their head because they were actually enacting lots of aspects of their identity. And it kind of fits in with Goffman's ideas of presentation of self, but with the kind of added thing that you can observe a lot of these things and they will tell you lots of information. So my idea was that I would put them all on a big piece of paper. So my dining room table was covered with a very large piece of paper, And for each transcript, I thought I'll actually just take each transcript, go through all the stuff that I've digested from it, and I'll start populating my maps and drawing some lines. So the idea was it was going to look like this, that I'd have my situational map, my social world map, my positional map, and everything would be nice and neat. Except it didn't quite work like that. Let's take, for example, there might be something in there about political decisions. Well, they always affect the NHS, and they always affect how services are organised. One of the things that might happen would be multidisciplinary team working could be suggested as a way forward for providing a service. But multidisciplinary teams, I thought, are they situational? Are they social world? You could argue either way, so I plunked them a little bit on the border. They're populated by people who have training from various professional bodies and answer to regulatory authorities. But they also bring all their own motivation, their principles, their preferences, aspirations, accepted practices. And these feed through to their sense of self, sense of identity, and how they see their roles and responsibilities. Let's not forget the patients. There's an interaction that goes on there as well. And the public and citizens, they kind of feed back a little bit towards the political decisions. And disease-specific pressure groups, they're certainly trying to influence political decisions and have an interaction with patients, both information and influence. And so it just gets more and more complicated. So suddenly, I didn't have my 3 separate maps anymore, which is what Clark had described. I had this, 12 of them, covered in lines. So what was I going to do? What I realised was that lots and lots of connections were going between both the situational map and the social world map to the positional map. So what I thought was actually, there's something going on here about how these people are as people, their sense of themselves and who they are and what they're doing, that is making them interact in certain ways with both the social world and the situation. First we'll look at just a few examples that are pulled out of the position to position map. So we're still in the traditional form looking at the vertical map, okay? A few of the things that I picked up from that, they talked about self, they talked about how they like to work, they talked about finding a pattern of work or a place of work that actually suited them, and they talked about a bit of self-preservation as well. We haven't got time to go through all of these, and this is just a fraction of all the dozens and dozens that there were. But just pick out a couple. This was a doctor who talked about developing work roles where he could achieve something. He actually talked about how he was driven to do meaningful work. That was part of his identity. It must be meaningful. There was just no point in doing something that didn't help anybody. A doctor talking about abandoning her outside leisure activities. Completely set it to one side because she didn't just want to succeed, she actually wanted to excel. And she wasn't even thinking of going to be a professor or something very elitist. She actually wanted to give really good clinical services to her patients. How you like to work. This doctor talked about a lot of the psychological support she would give to her patients, actually likened her role to what used to be performed by a parish priest or a clergy. She wanted to engage, she was very connected to the people, she'd actually grown up in that area, it was quite a deprived community, she was giving back. Pattern of work that suits. If you take, for example, having an active and predominantly clinical role, this was a person who wanted to actually be there doing the clinical work, not just talking about it. And self-preservation. The guy who was completely devastated, he had made an error as a junior doctor, got his calculations slightly wrong. Now, fortunately in this case, the consequences were not huge, but he was still living with that and still thinking about it 25 years later. And his actual way of seeing himself was being innovative and producing really good outcomes. So clearly there's a bit of a conflict going on there. When we step out from the positional to the social world, what are we going to see? These are the relationships, the negotiations of team activity and so on. But what do doctors actually say about it? I've just picked out one about the medical colleagues. This particular doctor was completely exasperated by handwritten illegible notes coming from hospital consultants because he thought that actually communication should be clear, should be concise, there should be no room for error. This was just not acceptable. Relationships with patients formed a lot of the conversations, actually. We have a doctor who organised his own work to include both long-term and short-term patients. He was actually an anaesthetist by training, but because anaesthetists get involved in pain management, he also had chronic pain clinics. So he was finding that he liked this nice balance between the quick fix of an administered anaesthetic, everything done, end of story, and a long-term relationship with some other patients who were negotiating a very long and painful journey, sometimes with some success, but sometimes it was a lot of support going on. Another who talked about empowering patients towards more effective self-care, and saw working with patients as being a privilege. Relationships with managers and their specific required actions was quite a tricky area for a lot of people. Sometimes people would move to a less hierarchical organisation because they didn't really like to be told what to do. Development of an embattled mentality when there just was poor communication, low acceptance of ideas that the doctors would put forward. Sometimes they withdrew. They could work with national networks. This was a histopathologist, as it happens. They really didn't get on with their local management team at all. Wanted to work in different ways, which would actually, in his view, save the NHS a load of money, but the managers weren't open to that idea. Negotiating teams was a very rich piece of aspect of the research. Some teams worked well, and some teams were really quite tricky. The interface with some teams for some doctors hadn't worked at all. Yet with another team, which was very focused on a task that they had to complete, that they would complete together, even though they were from different backgrounds, because they were cohesive and they had good working relationships, that worked well. There was another doctor who spoke about how her multidisciplinary team, a new consultant had joined the team whose way of working wasn't in line with the rest of the team. And actually, even though she was the leader of the team, she was very happy to sit back and allow the specialist nurses to say, we don't work like that in this team. Relationships with junior medical colleagues were a little bit upsy-downsy. There were some who get a real buzz from teaching. There was one who in particular devoted quite a bit of time and energy to dealing with trainees who were in some difficulty. They were failing to progress according to the standards that were required, because she felt that she wanted to give back to other colleagues and share the knowledge that she had gained. She was very happy to get involved in that. We move a step further to look at the positional and situational relationship. And obviously we're talking now about the management structures, work contracts, external regulations and so on. When things change and things have to be discussed, there are long management meetings. This particular consultant could see just how many hours he wasted every week, every month, every year, sitting in meetings which achieved little. He didn't feel he really had to be party to changing light bulbs. He wanted to be doing something that was a bit more than that, because his clinical role was important. But actually, because somebody had to be at the meetings to represent his team, his department, whatever, somebody had to do it, so therefore he was having less clinical input because of that. There was another who could see that from his general practice situation, there were possible threats to his practice actually continuing to be viable. He just made a decision. I'm not going to worry about that. I can't do anything about it. I'll just sit nicely in my own space and get on with what I know I can do. But very much because of where he is, he can take that attitude. When it comes to changing contracts, there are certain things that are valued at a greater level, some things that are devalued that doctors have wanted to do before. And sometimes they became frustrated. There was one who talked about excellence being dead. He was very much of the opinion that doctors really should be in a position to move things forward constantly, to try to be innovative, try to look for new solutions, new ways of doing things. And the idea that he was being limited by protocols and guidelines was really quite frustrating for him, really. Another who kept saying he wasn't motivated by money, but actually I think he spoke more about money and making money than the whole of the rest of the interviewees put together. So interesting to pick those things out of it. When it comes to external regulation, we know that things have moved a long way from the GMC just keeping a sort of distant eye on things. There are lots of regulatory systems and testings and audits and so on. But actually, in microcosm, the anaesthetist was talking about how a system had been brought in to kind of tick off boxes before someone goes in theatre and just make sure everything's sorted out in detail. But he felt that actually that was just getting in the way. He felt that his team should have sufficient inbuilt professionalism and know what they were doing so that would get done anyway. And he thought that if you keep going down the path that says we just tick boxes, then when something happens that isn't in a box, you're sunk, because no one's actually paying attention to the whole picture. There was another doctor who actually made a self-referral to the GMC. She'd been ill. She felt that she didn't want to make an error, so she would report herself to the GMC for monitoring and support, and actually found that that worked very well. When it comes to putting professional behaviour into practice, there's one doctor who kept trying to get her practice up to speed with the PWOF, the performance-related mechanism that had been brought into place in 2004. But actually she was spending more and more time trying to pick up these points, which in theory might improve the care of some patients, but she couldn't see that it was improving the care of them all. And certainly she was working very, very hard, and she was prepared to put in that work, but not all of her team were behind her. So there'd been a little bit of a division in the team because she was trying to keep pace with it and not everyone else was joining in. And again, job becoming more and more complex, more intense effort needed. People who are highly committed try to go with those sorts of agendas. The people who are not highly committed will tend to actually possibly cut corners. So what to do once I got all this? How might I actually look at what was happening with medical identity? Well, actually, I had to go back and just look at all the data. There is no escaping going back and looking at the data again. And then I had to pull it all together and see where I got to, and try and pick out patterns, to pick out the categories that I might use again to actually pull things together. And in brief, from what the data, not just what I've shown you, but lots of others, it seemed that since Frieson's work in the 1980s, professional authority, which was quite prominent then, had become very challenged. Autonomy is now curtailed because there are so many protocols, guidelines, and you mustn't do this and you mustn't do that. Self-regulation is largely not trusted anymore, and clinical mentality is in transition. There's lots of debate, how much of the evidence base is actually applicable to the patient in front of you. Technology, huge thing since the 1980s. It's there with access to information, both for doctors and for patients. It's always monitoring performance. The trick is working out what its monitoring actually means. My other task was to build a thesis. And although it's not possible to see it very easily, all those things that were in there about medical identity, in their little boxes, they all began to contribute to different chapters that were things that looked like they were worth writing about. So I had one on early career development, one on the technologies and recording and monitoring and how that was affecting consultations and how doctors worked. A very sizable chapter on negotiating teamwork. Another which I actually just looked at core and medical identity as such. And another one which was in a very tricky area of accountability, is where practices were actually ethical, where people were taking proper responsibility or where they might not.